Transformation Roundtable. Today, I am so excited because Alene Nitzky is with me, and we are going to be discussing gaps in cancer care. And she has been a nurse for a long time, and now she has her own business, which we want to talk about how that is possible for all the nurses watching today, that you can too get away from institutional nursing medicine and all of the abuses that are involved with that. So welcome, Alene. What a beautiful name.
Thank you. Okay, well,
yeah, tell us about how excited you are to be doing what you're doing, and you're out of the what you call institutional nursing, the institutional medicine, medical care that we all pretty much are sick of. Patients are sick of it. You never hear a patient really be excited about going into a hospital.
Yeah, that's for sure. Yeah. Well, nurses really need to do more speaking up, but there are a lot of reasons for that, and I'm not gonna get too far into that. But I think if I talk about my own experience, I'll touch on some of those things. But just how I came to nursing, when I never thought I would be a nurse. Really, I have a background in natural resources, and I'm also an ultra endurance runner, and I've been running for 30 years and competing, and so I was interested in exercise physiology. So what I did was I ended up studying health benefits of recreation in graduate school, and I got a doctorate in recreation resources. And then I taught exercise science for a couple of years in a small college, and then I started my own personal training business. And I worked with women over 40 who had chronic health conditions. And while I was doing that, I was realizing that there were a lot of needs that weren't being addressed by the medical community. They would treat their health condition, but they weren't dealing with the quality of life issue very well. And so that was an opportunity for me to work with them and help them with that. But I felt like I needed more understanding of their medical conditions and what was going on with them, just the whole pathophysiology of it, and then also how it was affecting their lives and how we could address that better. So anyway, to make a long story short, I ended up going to nursing school. And when I got out of nursing school, I started in critical care, and I worked there for several years, and then I was really interested in oncology. So what I did was I spent a lot of time attending support groups and talking with people who had been through the cancer experience, patients and caregivers, and listening to what their needs were, because I found the same thing, that a lot of needs were not being in traditional medicine. And anyway, I ended up going to oncology and working in an oncology, in a hospital-based infusion clinic. So I gave chemotherapy and a lot of supportive treatments for people with oncology, with cancer and other hematological disorders. And anyway, with nursing, we have the problem in nursing of nurses being good advocates for their patients, but not being very good advocates for themselves.
Right.
And a lot of times what I was finding was that there was a lot of fear. People were really afraid to speak out and talk about what they needed as nurses. They needed the support to be able to do a good job in patient care. And what happens a lot is the administration, even at some of the hospitals, just for example, hospitals with magnet status, or that tend to be a little bit better for nurses as far as working conditions.
Yeah.
A lot of times, even though they would say they gave nurses a voice, they might allow nurses to speak their mind and give some input. But a lot of times what happened was that they'd already made up their minds, the administration. They knew what they were going to do. And sometimes they'd just say, well, yeah, we listen to our nurses because we let them speak. But they already made up their mind about what they were going to do, and it really didn't make any difference what nurses said. They were just going to go ahead with their plan anyway.
Right.
And, that, to me, I always felt very underutilized as a nurse, and I felt like a lot of the other nurses, also the same for all the nurses, that there was so much that we could contribute to patient care and to disease management and quality of life and how we treated the whole person.
Right.
But we weren't being used for that. Instead we were the gophers, and we were rushing around and more and more doing documentation, and sometimes you felt like a waitress on roller skates. There were all these misuses of nurses, and
Right.
nurses did complain among themselves about it, but it never went anywhere, and they never really were able to make changes in their work environment. So after a while, I just felt like I could do a better job of addressing patient needs outside of that institution.
Mm-hmm.
And so really, my passion lies with helping people improve their quality of life. And that's something that I really wasn't able to do directly in a hospital environment.
Yeah, I'll never forget the time, let's see here, that when I was in training as a nurse, and I was in the oncology unit following an oncology nurse, as she was administering chemotherapy, and there was a break in what we were doing, and I said to her, "Do you believe in chemotherapy?" And I expected her to say yes, and she said, "No." And I didn't know what to do with that. So I think that's kind of like at the base of what we all kind of are involved with. We believe in patient care. We love our patients. We want to do the best by our patients. We want to be patient advocates. But what happens so often is that there's too much actually that interferes with our ability to do that.
Yeah.
What do you think?
Yes, I agree, and I think that I've always felt that if nurses ran healthcare, we would all be so much better off, because we come from a holistic approach, and when you figure in the way medicine is always looked at as so important, and it is important. I mean, there's definitely a place for medicine in healthcare, and it's huge. I mean, we've made huge advances in treating disease and preventing disease, but medicine is not the whole picture. And when we only pay attention to medicine because of what it brings the money in, we don't do as good a job at care. And so I think that we need more care and less medicine. I think more care would help us use less medicine. And if we looked at our patients' lives and their quality of life, we would make a lot more advances. The other thing too is the business model of healthcare. Administrators and people who are executives in healthcare, for the most part, were not trained in healthcare. They don't know what direct patient care is. And really, I have yet to hear about an administrator or an executive who actually would shadow a nurse through an entire shift and go through every little step that nurse has to go through during the day to take care of their patient load. I think that if that could happen, we would have a transformation. At least if we had administrators and executives who really cared about quality of care. Unfortunately, I'm not seeing a lot of that emphasized.
Yes, well, if it would happen, if you would have an administrator follow us around, even like you say, for one shift, the whole thing would change. We would have more respect. We would have we would be on the boards of these decision-making, policy-making situations. And it's true. I mean, I think it's almost like the majority of nurses are women, and I think that's part of the problem. There is so much. Women still are in a subordinate position in our society, even though people don't think so. We are in the American society, and that's not supposed to happen, but it does happen, and it is happening all the time. And nurses have to really address that issue, I think, and what we're talking about. And if we want to take back nursing, as they say, we have to address the fact that nursing is a woman's issue.
It sure is. It sure is. And yeah, I mean, I love having men in nursing. It seems like I always enjoyed the men who were nurses who I worked with. It gave a nice it just was a really nice break from just an all women's crew. But men don't go into nursing because of a lot of the they know that there's less respect and that it is a struggle. And
Yes.
I think we'd have more men in nursing if nursing had more respect. So, yeah, it's unfortunate.
It would be true too if more men would get involved in nursing. What would happen is that you'd see more of a respect taking place in a much more accelerated rate, which is sad, very sad.
Yeah, yeah.
So we were going to talk about gaps in cancer care. Tell us what it is that interests you about that.
Okay. Well, like I said, as I was going into oncology, I was making that transition from critical care to oncology. I was listening to a lot of patients and their caregivers and hearing what they were experiencing and what were the shortcomings of medicine and the way their treatment went. And so, I was hearing a lot of the same themes over and over again, and there were a lot of things missing in the whole process. I mean, from the time they were diagnosed, or even before they were diagnosed, as far as knowledge. And I'm going to talk about that here in just a minute. But there were so many things left out, and it just seemed like somebody needed to address that. And we weren't going anywhere. We weren't making progress. Now, a little over 10 years ago, the Institute of Medicine put out a report. It was called Lost in Transition. And it addressed the need for what they called survivorship care. So people they called cancer survivors who had been through treatment, who had been diagnosed and then went through treatment. And then after treatment, they were kind of lost. They just went back to their lives, and nobody really tracked what happened to them, and nobody was really paying attention to their needs for follow-up care. So over the time that has ensued since that report, we have made a lot of progress in some areas. For example, oncologists now very often, not always, but very often will provide a follow-up care plan, or something called a survivorship plan, for a patient to use after treatment so that they know when they need to have follow-up screenings like colonoscopies, mammograms, and then PET scans to look to see if the cancer has returned, or make sure they're still cancer-free. Anyway, there have been a number of changes in how we address post-treatment care, but there's still a lot of gaps left. And so I think the best way to talk about this would be to just kind of look at it as a spectrum, like a trajectory of cancer care, from before to after treatment. And then I definitely want to bring in the topic of people living with metastatic disease, because that's something that gets ignored a lot when we talk, like in Breast Cancer Awareness Month and other efforts to make the public more aware. We always leave out people who are living with cancer, and that is a large number of people, and they deserve quality of life too. So I'm going to talk about these gaps in cancer care and talk about what happens after treatment, but I also want to remind everyone that there are a lot of people who have ongoing treatment, and they're living with metastatic disease, but they can actually live for a very long time and have very good quality of life if things are addressed well.
Mm-hmm. Mm-hmm.
So one of the things that happens if you're talking about before a cancer diagnosis, we have a lot of lack of knowledge and education in this country as far as how to prevent chronic disease.
Mm-hmm.
And so when I talk about chronic disease, I'm also talking about cancer. But we don't exercise enough, we don't eat well, there's a lot of substance use and abuse, a lot of exposures in the environment to toxic chemicals, and just all kinds of things out there that we encounter during our lives that are linked to cancer,
Right.
or chronic disease. We really get very little health education in the schools about cancer. There are, we talk about, in primary care, we do the screenings. They talk about prevention that way. But nobody really learns much about cancer except what they hear in the media. And unless a person has been directly involved with the care of a family member or a friend who has cancer, they're unlikely to understand what goes on in cancer care.
That's true.
Yeah. So, there are a lot of misconceptions and myths and misinformation out there. Also, there is a lot of, there's some quackery, there are some questionable treatments, and then there are also a lot of non-traditional treatments and complementary treatments, and there's a whole list of these, and a lot of times people don't know what is valid and what is good and what is not, because they hear about chemotherapy and then they'll hear about all these other things, and some of these things are very good, things like acupuncture and certain types of exercise therapies, but you've also got these people who sell snake oil. You've got some people who have products that really have no basis in no evidence for treatment. So people don't really know a lot about what works for cancer. So the lack of knowledge is a huge problem. Also, our unwillingness to address our mortality is another huge gap.
Huge. That's huge. Yes. Mm-hmm.
Yeah, and we could do a whole other webinar on this, but I'm just going to discuss this briefly. People don't do advance directives. They don't discuss death as a part of life, and the topic gets avoided. And if you're unprepared for death, that has a lot of spiritual and emotional and social and financial implications for everyone. Your whole family and everyone close to you. So we really need to address that. And that is something that primary care should be addressing.
And they're afraid of their own mortality as well. That's why they don't address it. And
right.
Cancer is basically, in the doctor's eyes, a failure. And if the patient dies, that's a failure.
That's right. That's very true, and that's why a lot of times people's treatment options don't get fully discussed.
Yeah.
I think it's really important at the outset when a person is first diagnosed with cancer and before, we need to have some discussions about what is quality of life. What does each person consider quality of life? It's going to be different for everyone, but a lot of these treatments, can make your quality of life very bad.
Right.
A lot of the chemotherapies, they can be very, very difficult to get through. And does a person really want that? That's something that needs to be discussed. And we need to admit that curing something, it doesn't always have to be our goal, and that sometimes it's better to choose what quality of life is, and then live according to that.
Right. Well, you know that right to death scenario that happened in Oregon, the 29-year-old brain cancer patient who opted to die. I thought that was so brave.
Yeah. Yeah. And I think that needs to be part of the discussion.
Right.
With all of this. Yeah. So, to have a little advanced understanding, if people had a little bit more understanding of what cancer is and the different reasons why certain treatments do and don't work, because when you think about it, they say these are the current statistics that 1/3 to 1/2 of all people will have cancer at some point in their lives. So if it's that prevalent, we need to be talking about it.
Right.
We need more information because it affects so much of our population. So then one more gap that before the cancer is even diagnosed is understanding that if you do get treated for cancer or if you have a chronic disease, it's a process. It's a whole process of treatment and working through the symptoms and the side effects. It's not just we throw chemotherapy at it and it goes away or a person dies and then that's it. It's not that simple. I always like to use this example. It's a terrible example, but when you see people on TV who are being shot, nobody ever sees what happens to that person after they get shot. Like, they don't see that person when they're in the ICU and they've got tubes in every orifice and they're, recovering from a traumatic brain injury and have all this rehab. We don't see what happens to people during the treatment and the healing process. And for example, with cancer, a lot of times we'll see bald people. We'll see pictures of bald people, but nobody ever shows you the pictures of the ports or the medications they're taking or how fatigued they are, the radiation burns, feeding tubes. We don't see all of that. So there's a big lack of awareness of what cancer can be all about.
It's like hidden. It's purposely hidden.
Yeah. Yeah. Mm-hmm. So anyway, during cancer treatment, there are a lot of gaps. And talking about the big picture and treatment options and the long-term effects of some of these treatments and things that might come back later, that needs to be discussed. And to some extent it is, but I can tell you right now that I wish I had $1 for every person who told me after they'd been through cancer treatment that nobody ever told me it was going to be like this.
Oh.
And that years after treatment, they are still suffering from a lot of effects of what they went.
I think it must be post-traumatic stress in a lot of cases with these people.
It is, yeah, it is definitely. Yeah, and I'm going to talk a little bit more about that. But during cancer treatment, one of the huge gaps is helping caregivers. Caregiver support and respite for caregivers is vitally important, and we need to provide better services for people because they get isolated in their homes and caregivers need support to manage the patient, and they need a lot of education. And I know that some doctors do a better job of this than others, but a lot of the caregivers I've talked to really don't have an understanding of what's going on and how for example, how chemotherapy might affect the person. The doctors will tell them, if you have a fever, if you have 100.4 or greater, definitely call us right away or go to the emergency room. What happens is you have people dealing with ongoing symptoms at home, and they're not being managed very well.
Yeah.
They've got fatigue, they've got nausea, pain, things that people can end up going to the emergency department because there was a miscommunication or somebody missed something, at the doctor's office. Maybe the caregiver doesn't have all the information they need.
Right.
I would all the time when I worked in the infusion clinic, we would have patients coming in to us on an emergency basis, like the doctor, they would call the doctor and the doctor would call us and say, hey, we need to get so-and-so in for, potassium or magnesium infusion. And these were not planned. It was just like we have to fit them in somehow. And when they'd show up, we find out, well, they've been having diarrhea for the past week, or they have a fever, or vomiting, or feeding. I mean, meds are not addressing all of the needs. Their meds are inadequate. And then you talk to the caregiver or the patient, and they'd say, well, I didn't want to call the doctor and bug them.
Oh.
And then the person ends up in, they're septic. They go to the ER and they're septic, or they have heart arrhythmias because their potassium is so low.
Huge.
Yeah, and it's sad because, we need to make sure people know that we're there for them in the medical community. We need to make sure that they know that they can get their needs addressed. And when they go in the doctor's office and the doctor is rushed and only has so much time with them, the patient gets the message that the doctor is too busy for them. So, and the doctor is too busy. That's one of the problems. It's not that they don't want to give good care. They do want to give good care. But the way we work in healthcare is such a dysfunctional system. You can't work for the benefit of the patient. You need to take care of the person's needs. And when the doctor only has 15 minutes to deal with a very ill patient, you're not gonna benefit the patient.
No.
So, that's one of the most frustrating parts for me. Is I would love to see the physicians work more with everyone else, bringing nurses and social workers and everyone together for the benefit of the patient.
Right.
So that's and that's I'm talking about during treatment. And then as far as follow-up care after treatment or with ongoing treatment for metastatic disease, there's I have this idea. Before, when a person is first diagnosed with cancer, they have this thing called a tumor board, where they'll have all the professionals in medicine who are going to be dealing with that person's case get together, and they talk about how to address that tumor, how to address that cancer. So you have oncologists, surgeons, radiation oncologists, social workers, maybe a patient navigator. They all come together to put their ideas together in how to treat the case. They're a tumor board. Okay. So what I think is that we drop the ball after treatment, and we need to bring those people back together. At least we need to bring the oncologist, the primary care physician, maybe someone like a health coach like myself, and somebody with a nursing or social work background, and have this board meet at periodically, just like you'd get your follow-up colonoscopy or mammogram periodically, and talk about what are the unmet needs, what are the things that people still need in care after treatment, because there are so many symptoms and lasting effects. People are always worried about recurrence, and the client needs to be part of that conversation. They need to be involved. All of these parties need to be involved so that we can provide good care for the person after treatment and down the road. And so, if it were up to me, I would say, let's do this. Let's have a quality of life board, instead of
right.
Let's have a quality of life board and continue to address these issues. And, you can address those lingering concerns. And that, I think, would be a true team approach and a true patient-centered approach to care. Because what we talk about in patient-centered care right now is what we're doing in the hospital or in outpatient settings, and it really only has to do with dealing with the acute illness or symptom management. That's illness-centered care, and it's crisis-centered care. What we need to do is change our approach so that we are really treating the patient, the whole person, as they go through life after treatment, and help them, address lifestyle issues and behavioral issues that need to be addressed if they're going to, reduce the risk of recurrence and to feel better or to live a good quality of life if they have metastatic disease. All of this needs to be happening. We need to be talking about the person's total needs.
Right. Now, where you are working now and your role now, do you actually have that kind of influence, and can you start those kinds of programs where you are now?
Well, that I would like to. I have not. I have not figured out yet a way to get my foot in the door consistently with the medical community. It's been that's been my biggest challenge as a new business owner, is getting the medical community on board. One of the things I see is that they can see me as a competitor, which I think is silly, um, because they do their thing and I do my thing, and we could work together and do a lot of really great things for patients.
I think so, yeah.
Yeah, and so I'm not seeing I'm seeing a lot of this. It's the competition, and part of it is a function of local politics in healthcare, because we have two major hospital systems in our area that are just competing for business, and it's just crazy. So
it's so old school,
Yeah, yeah. It's like, why don't we think about the benefit of the patient and how we can all work together to make it better for them instead of protecting our turf? But that's just where we are right now, and we'll see where healthcare takes us.
Do you have patients that come to you for coaching, as it were?
Yes.
And what kind of website can you share with us for that? Because it seems to me it wouldn't have to be a local thing. People from all over, you could have an internet-based business to do this sort of thing.
Absolutely, and I can, and I do. I've talked with several people outside of town about my services, and I've been working with somebody out in California.
Oh, good.
In health coaching. So yes, that is something that I plan to expand. And so it's sunspiritwellnessservices.com. It's all one word, sunspiritwellnessservices.com. That's my website. And there's a contact page on there where you can directly send me an email or inquiries about what I do.
Oh, that's great. And I would think, as we were saying before we got on here, that you've only really been doing this a year, and it takes patience and it takes time, but once you get the word out, cancer is a huge, as you have pointed out, there is a huge amount of diagnosis that it affects all of us, whether it's ourselves, it's our people in our family. And I was told by my homeopathic physician, whom I was raised with, that everybody gets cancer at one time in their life and they just don't know it. It comes and it goes. It comes and it goes. And that just sort of changes the whole scene when you think that things are happening inside your body that you can control with health giving, nurturing, self-love kind of things. It's very important to address that side of things with people.
Yeah, and I think that we're starting to become more aware now that overdiagnosis and overtreatment is a big problem. And it may be that we have our immune systems. We have cancers growing in our bodies at some point, and if our immune system can take over and deal with it, then it does not become a problem. It doesn't continue to grow uncontrollably. So there's so much more to the picture that we still don't know.
Yes.
But I think when we focus on just medicine, traditional medicine, and we're too rigid in our thinking about processing people through the healthcare system like a factory.
Right.
I think that we're not really doing what we should be doing. I think we should be caring for people and making their lives as giving them as good quality of life as they would like. And so we need to do the things that will help them achieve that. And sometimes traditional medicine is not the answer.
Well, let's look at too. Oftentimes a person is, it seems like a lot of patients are treated the exact same way, and there isn't any kind of taking the person's unique qualities into account when these treatment regimens are being prescribed. Is that something you've seen?
Oh yeah, yeah, definitely. There people, and I see that a lot too after treatment because people have such different. People's lives are so different. So what affects one person one way, that can be just very disturbing and upsetting, might not even faze somebody else.
Yes.
And it depends on it depends on their perception of it and their attitude. It depends on their knowledge, their sometimes their education level, their just their ability to cope with things and their coping style.
Right.
So people are very different, and one of the things that I do is I help people incorporate those healthy behaviors into their lifestyles, into what works for them, and there's never a one size fits all.
That's right.
I'm sorry, that is one of the problems with the way some of the doctors go about with the survivorship plans. They'll have the person come in, they'll say, okay, we're going to give you an individualized survivorship plan. And what they do is they give them a rundown of all the treatment that they've had, and all the medications and surgery, radiation, whatever, and they give them a timetable for follow-up care. So they're giving them that part is individualized. But then they tell them, okay, so you need to exercise, you need to eat right, you need to manage your stress. And here are some handouts that you can read that will help you do that.
Well, think about it this way. Physicians have no idea how to handle their own stress.
And they are some of the most stressed out people.
Absolutely.
And unhealthy people that you'll ever run across, and they don't know that. And it's okay, because that's not what they're trained to do. They're trained in the practice of medicine. But they need to be able to reach out and bring the other people in who can do that for their
patients. Absolutely. Instead of thinking that some sort of ego reason for not doing that.
Right. And that's one of the things, that's one of the other frustrations for me. But some of these gaps in care for after treatment, for example, you've got people will finish treatment, they'll be anemic and they're fatigued, and the doctor never told them that hey, it takes 120 days for a red blood cell to mature. So it might be 4 months before some of your anemia resolves. It might take even longer. And the person is sitting here trying to they say exercise. The person goes out and tries to exercise, and they're so winded they can't do it because they don't have their hematocrit is so, or their hemoglobin is so low, and people don't, the doctors don't tell them that.
Right.
Or they give them the aromatase inhibitors or tamoxifen for estrogen receptor positive cancers. Those cause a lot of joint pain and fatigue and hot flashes and a lot of symptoms, and patients will be on those for 10 years.
Right.
And some of those effects are just unbearable. And how to deal with those? We've either got to have better drugs, or we've got to have better ways to manage these things, because they affect quality of life. And people's support systems change. There's a lot of social upheaval. People's friends, they might be there for them when they're going through chemo, but then after they're done, excuse me, the friends might not understand that they may see things completely differently. Their priorities have changed.
Right.
And there's still a lot of this trauma that they have to process and deal with.
Well, certainly a spiritual discipline would really, really be part of what needs to be integrated into a cancer survivor's regimen of life.
Yes, and that is a huge part of it. And people really they find a lot of changes in just their whole approach to life. I mean, after an experience like this.
Well, even
And
at the very moment of diagnosis, it can and often is an entry point into spirituality. That would maybe the person never even thought about it before, but suddenly that's what all they think about.
right, right, yeah. And then that also that affects the family, the family structure, and just how the relationships, and you know, uh, for example, you've got, if the caregiver uh, still, just say the spouse is the caregiver, and the spouse is used to the person seeing things a certain way, and then all of a sudden they get this cancer diagnosis, and it just, it's complete upheaval of
Yes.
the whole existence.
And
And
it's expensive, huh? On top of everything else, it's very expensive.
yeah,
And our healthcare system is very poor in regarding the taking care of people. Health insurance is pathetic. It's not covering anything anymore, and those
yeah,
huge deductibles, that kind of thing.
yeah. And the insurance claim denials, which are just horrible because, when you have no energy and you're sick, and you're having to deal with insurance companies, that is just maddening. And there are also a lot of employment issues. Our Family and Medical Leave Act, we used to not have that, but it still doesn't really put a dent in what people need for time off, because when you're talking about dozens and dozens of doctor's appointments and uh, and other appointments, both for the caregiver and the patient, um, that just takes an incredible amount of time. And some employers are better than others about understanding those needs, but there's still a lot of employment discrimination. Even with the
Yes.
ADA in place, there's still a lot of employment discrimination. In fact, um, I just saw some statistics on how many people are still unemployed, even though they would like to be employed. How many are still unemployed for years after they've gone through cancer treatment
Oh my.
for various reasons. And and people would like to be productive. They would like to be able to re-enter the workforce, but they might not be able to keep up at the pace they used to. Where they used to work.
Right.
And employers don't always understand that, and I think it's unfortunate because we've got all these people out there who, would like to contribute something, but not they're not being allowed a place.
Right. So, what is your personal vision for how you can personally contribute to this state of affairs with cancer patients?
Well, I want to address it in several ways. I really love working with the individual clients, because I I love to sit with them and ask a million questions about what goes on in their lives, and actually observe them in the home, and see what they're like with their other, their family members, and just how things work, so I get an idea of what would work for their lifestyle.
Mm-hmm.
But also, I really, I just lost my train of thought there for a second. It'll come back in a
Yeah,
second.
welcome back.
Yeah, ask me the question again. That'll help.
How do you envision yourself contributing? How do you envision your own contribution in helping cancer patients with, and also integrating everything we've talked about in terms of getting in there and working with doctors and nurses and being the coach that you are with your exercise and physical fitness. How do you see yourself in contributing in this way, and say in the next year?
Things like what we're doing right now is getting the word out there, and talking to as many people as possible, and making them aware that there are these needs, and we need to work together in the healthcare community. As I get a chance to talk to doctors, which is very difficult, it's very hard to get in to see them, but if I run into them in town and I get a chance to talk with them, and going to support groups and doing radio shows and talking to any kind of cancer-related groups, like nonprofit organizations, getting the word out in the community, to let people know that this is something that needs to be changed, and this is how, I'm proposing something here. I would love to get other people on board with me, and
Right.
and figure out a way to address this. So, I would love to have the cooperation of the traditional healthcare community. I would love to talk with the doctors, and it's just going to be a matter of time and just getting the message out there.
Right.
It's just consistent and being as vocal as possible and just not letting up. And my clients actually do a very good job of talking about this. And I have one client who has just been a fantastic advocate for me. Every time she goes to a doctor, she's been telling them about me, and
Well, that's perfect.
yeah. So that's what I need is
Yes.
to more of that, and just keep putting the word out there. And also through writing, I write a column in the local paper
Oh,
occasionally.
that's great. Yeah.
Yeah, and then just anywhere, getting it out on the internet and social media. So there are a lot of ways to get it out there, but it's just being persistent and just keep pounding away at that that message, and just let everybody know that yeah, there are ideas out there. We need to make some changes, and that's all.
Oh,
That's all.
perfect. So thank you for coming on the Google Hangout today and to the Nursing Career Transformation Roundtable. It has been beautiful talking with you, and I wish you well, and I will keep your vision in my mind for you, and hope that everything turns out exactly as you wish. So that's great.
Well, thank you.
Thank you. Namaste.
Bye.
Bye-bye.
Bye.